So recently we had an individual who was a collegiate lacrosse player who had suffered an elbow dislocation. Now, when they went to see their orthopedic, the orthopedic did give them the option, based on what they had found on the MRI, that the ligamentous structure around the elbow and the elbow joint in general was going to be one that he felt comfortable with attempting conservative management with and not going directly to surgical intervention. So with this individual, they came in for PT. They had already been to the orthopedic, and the orthopedic gave them a rough time frame for returning to sport. They said it's going to be roughly 4 months. It could be longer, it could be a little bit shorter, but game plan on this being roughly a 4-month rehab. So what I like to do with these individuals, if I am not familiar with the orthopedic who's referring them to me, is just reaching out to them either early on, right after the eval, or if I know the patient's going to return for a follow-up appointment in the upcoming weeks, and my question is not going to dictate what I need to do early on, but maybe later on discharge planning. When I send my progress report with the patient, I'll also add some specific questions that I'd like to get answered by the orthopedic. But my thought that I always want to know for this is, how conservative or aggressive does the orthopedic want to be as we're working through range of motion and strength training during the early phases of rehab? And whether it's an elbow or whether it's a shoulder or whether it's a kneecap, you have some different philosophies on how aggressive or how conservative they want you to be with pushing range of motion early and pushing strength early. I've had some orthopedics that want to be a little bit more conservative, and they say, let things calm down. Don't worry about regaining maximal range of motion early. We don't want to be stretching and stressing tissues that had just gone through a traumatic incident. I've had other orthopedics that say, hey, based on the MRI and what I saw with my clinical exam, I'm fine with you going on an as tolerated approach from a range of motion and from a strength standpoint. The joint is no longer grossly unstable with the types of activities you're going to be doing in early phase rehab. So just let pain, swelling, and overall symptom profile and tolerance be your guide. So with this individual in the early phases, it was very kind of basic rehab that we were going through, just restoring passive range of motion and active range of motion locally at the elbow and also at the wrist and forearm, mixing in some shoulder motions as well, just to get the compound movement of the elbow and the shoulder moving together, but also just to get him moving some relatively unaffected body parts to make him a little bit more comfortable with those tasks. Some soft tissue, some modalities were done as well, just for symptom management and pain management. But what I really try to do early on with these individuals is relay to them how some of the early active range of motion that we're going to do is going to directly translate in to the strength training that we're going to do. How just basic pronation, supination, elbow flexion, elbow extension is going to translate into some resisted activities in the weight room in the upcoming weeks. And if you can get them moving cleanly with active range of motion early on, your progression into the weight room can be relatively gradual, but early on, meaning just giving them either resistance band, resistance tube, or light hand weights to start bridging that gap from active range of motion to your higher levels of strength training that you're going to do later on, and not waiting too long to initiate some of those tasks. Now, when we get into the strength training phase, I'm a big fan of doing isolated work for elbow flexion, elbow extension, wrist pronation and supination, and wrist extension and flexion. And I think of that as no different as why you would want to isolate knee extension and knee flexion with hamstring and quad strength for somebody having a knee injury. The elbow is the same way, but you do need to factor in that rotational component of the forearm and how that's going to influence the ability to extend and flex the elbow comfortably and forcefully. Early on, from a strength training standpoint, we utilize BFR as a way to maximize localized tissue strength at the elbow and the forearm during times where we were relatively limited with how much mechanical load we could tolerate or put through that limb from a stability standpoint. So early on, as we did symptom management and range of motion, we were supplementing a lot of those range of motion tasks and very light resistance tasks with BFR, transitioning into the next phase, going into more heavier loads of resistance and more of our compound movements, and also getting into some different weight-bearing progressions as well. As we worked through that, a very important component to get into with this individual was upper extremity plyometrics. And his injury was a foosh injury, so we needed to get him comfortable with being able to tolerate absorption and impact of the upper extremity. Some early things that we did with this, very early, was just getting him into quadruped position and getting him weight bearing, then progressing into some bear holds, into some high planks, and then eventually from there just getting into your more traditional closed chain strength work. When you start to add impact and absorption for upper body, it's really just variations of a lot of those weight bearing tasks. So things such as positioning him in front of a table or a plinth and having him fall and catch himself at the table, or putting him in a kneeling position and falling down into a push-up position. With this, you can influence whether you're falling to a bilateral position, maybe we are staggered or asymmetrical, with one hand higher or lower, or wider or more narrow. You could also fall onto objects of different heights. So maybe not having both hands go down to the ground, but putting a plate or some sort of block on the ground that's 2 inches high, and having him fall to an unlevel surface. And that's going to put different stresses through the elbow at different angles, and it's also going to force him to have to adapt to the environment that's in front of him that's not as predetermined and not as consistent as what it may just be if you're on a flat level surface. You can also treat upper extremity plyometrics very similar to lower extremity, where we talk about counter movement jumps, non-counter movement jumps for force production. We can also work on doing force production from a loaded position or from a down position in a push-up, where we're then pressing forcefully up. Or we could do a counter movement upper extremity plyo, where we're in a push-up position, we load into it, and then immediately press ourselves out of it. So all of the concepts you think for lower body with regards to non-counter movement and counter movement, how that influences their ability to produce force, utilize momentum in the stretch shortening cycle, you can put that into upper extremity as well. We talked about bilateral and asymmetrical loading earlier. You can also do that unilaterally. So from a absorption or an impact standpoint, doing some of those same falling drills onto one arm, going out maybe at an angle or off to the side, and then also doing that with some of our force production with single arm push-ups. Now, obviously a single arm push-up's challenging to do, so you may need to do that from an elevated position. Other things to keep in mind with plyometrics for upper body is what's the range of motion we're going through, and what's the rate of force production that we need to slow ourselves down or speed ourselves up. So with some of our catching and falling drills, having them practice where they catch and absorb through the full range of motion, lowering themselves to the ground slowly, almost like they're tapping on the brakes the whole time, versus going from a kneeling position, falling into that push-up and having to rapidly stop themselves upon impact. If you think from a sports environment, this is a lacrosse player. If they're playing defensive position and they have to body up with somebody and they need to make contact and hold their ground, no different than like an offensive lineman who needs to punch and engage and maintain that contact and that stiffness with the hand away from the body. As we get into those progressions, then it lends us into more of our sport-specific progressions. For him, working on some of our dodging, some of our stick work, passing, shooting, things that are going at a higher velocity, at a higher speed, also where that elbow is being stressed into different degrees of varus and valgus and some distractive forces as well. With lacrosse, it's highly variable in regards to the way that they're going to have to catch or throw. So getting them comfortable with all of the different arm slots and arm positions they can get into to carry out those tasks. And then going through our traditional upper extremity return to sport testing pattern. And we're going to dedicate a whole nother video to get into that, to show you all the different formal tests, what they mean, and what kind of valuable information you can get from that. Overall though, this individual had a very successful rehab. They were able to return to sport in the anticipated time frame. And with this individual, they were somebody that we were able to get them back into the competitive environment without having any exacerbations, without having any re-injuries, and they're now continuing their collegiate career. I don't want to say as if the injury ever happened, but they're back to playing at what their previous level was without having a detriment to performance or to confidence. So upper extremity, elbow dislocations, I've been practicing for 11 years. I've only gotten to work with a handful of these in the athletic environment that were conservatively managed. A lot of them ended up being surgically managed. So it can be a little bit daunting if you haven't seen one, but a lot of your training and reconditioning and rehab principles are consistent as you would with your postoperative patients. You just have a different timeline of what you're working with, and you need to really be on the same page with the orthopedic as to what their expectations are and how quickly or how conservative you need to be with the progression of their care.